The Management of Ovarian Hyperstimulation Syndrome, Green Tab Guideline Number 5, February 2016. Purpose and Scope. Ovarian Hyperstimulation Syndrome, or OHSS, is a complication of fertility treatment which uses pharmacological ovarian stimulation to increase the number of oocytes and therefore embryos available during assisted reproductive technology, or ART. In a minority of women undergoing treatment, the ovarian response exceeds that aimed for and results in a clinical condition with a specific pathophysiology. Ovarian hyperstimulation syndrome is associated with significant physical and psychosocial morbidity and has been associated with maternal death. However, in most cases, ovarian hyperstimulation syndrome is self-limiting and requires supportive management and monitoring while awaiting resolution. The key principles of ovarian hyperstimulation syndrome management are early recognition and the prompt assessment and treatment of women with moderate or severe ovarian hyperstimulation syndrome. Key pro-inflammatory mediators are believed to be involved in the pathogenesis. Introduction and background epidemiology. Exposure of ovaries to human chorionic gonadotropin, or HCG, or luteinizing hormone, or LH, following controlled ovarian stimulation by follicle stimulating hormone, or FSH, underlies most cases of ovarian hyperstimulation syndrome. Exposure of hyperstimulated ovaries to HCG leads to the production of pro-inflammatory mediators. Chief among these is vascular endothelial growth factor, or VEGF, but a variety of cytokines are likely to be involved in the pathogenesis and clinical features of ovarian hyperstimulation syndrome. The occurrence of ovarian enlargement with the local and systemic effects of pro-inflammatory mediators, including increased vascular permeability and a prothrombotic effect, is responsible for the clinical features of ovarian hyperstimulation syndrome. Increased vascular permeability leads to loss of fluid into the third space, manifesting as ascites, or less commonly, pleural and pericardial effusions. Women with severe ovarian hyperstimulation syndrome demonstrate hypovolemia with a typical loss of 20% of their calculated blood volume in the acute phase of ovarian hyperstimulation syndrome. Accompanying this hypovolemia is reduced serum osmolality and sodium. This paradoxical combination of hypovolemia and hypoosmolality has been ascribed to a reset of the osmotic thresholds of vasopressin and thus to lower osmolality and sodium levels as these women remain able to concentrate and dilute their urine around the new, lower level of osmolality. The parallel resetting of the osmotic thresholds is thought to explain the observed decreases in serum osmolality and sodium as opposed to electrolyte losses. Despite the growing number of cycles of assisted reproduction, the true incidence of ovarian hyperstimulation syndrome remains unknown because there is no mandatory reporting for mild and moderate cases. Incidence of ovarian hyperstimulation syndrome. What is the reported incidence of ovarian hyperstimulation syndrome? Clinicians must remain alert to the possibility of ovarian hyperstimulation syndrome in all women undergoing fertility treatment, and women should be counseled accordingly. The incidence of ovarian hyperstimulation syndrome varies between different types of fertility treatment, with treatments involving greater degrees of ovarian stimulation being associated with higher incidence. In cycles of conventional in vitro fertilization, or IVF, mild ovarian hyperstimulation syndrome has been estimated to affect around 1/3 of cycles, while the combined incidence of moderate or severe OHSS varies from 3.1% to 8%. Ovarian hyperstimulation syndrome is rare following ovulation induction with clomiphene or monofollicular ovulation induction with gonadotropins, but it has been reported. Very rarely, ovarian hyperstimulation syndrome may occur spontaneously in association with pregnancy. Certain patient and cycle characteristics increase the risk of ovarian hyperstimulation syndrome. Women with a previous history of OHSS, polycystic ovary syndrome, increased antral follicle count or AFC, or high levels of anti-Mullerian hormone or AMH are at an increased risk of ovarian hyperstimulation syndrome. Evidence from meta-analysis also shows a reduced risk of ovarian hyperstimulation syndrome in vitro fertilization cycles employing gonadotropin-releasing hormone antagonist compared with cycles where gonadotropin-releasing hormone agonists are used as part of the regimen for controlled ovarian hyperstimulation. However, ovarian hyperstimulation syndrome still occurs despite these preventive measures and can occur in patients and treatment cycles that do not meet any criteria that might be considered high risk for the development of OHSS. The outcome of treatment also influences the incidence, which is higher in cycles where conception occurs compared with cycles without conception, and higher still in cycles resulting in multiple pregnancy, highlighting the important role of endogenous human chorionic gonadotropin. Diagnosis of ovarian hyperstimulation syndrome. How is OHSS diagnosed, and what differential diagnosis should be considered? Clinicians need to be aware of the symptoms and signs of OHSS as the diagnosis is based on clinical criteria. In women presenting with severe abdominal pain or pyrexia, extra care should be taken to rule out other causes of the patient's symptoms. The input of clinicians' experience in the management of ovarian hyperstimulation syndrome should be obtained in such cases. The typical patient presents with abdominal distension and discomfort following the trigger injection used to promote final follicular maturation prior to oocyte retrieval. There may be a preceding history of an excessive ovarian response to stimulation. The time of presentation following trigger injection divides patients into two groups: early and late ovarian hyperstimulation syndrome. Early OHSS usually presents within 7 days of the human chorionic gonadotropin injection and is usually associated with an excessive ovarian response. Late OHSS typically presents 10 or more days after the HCG injection and is usually the result of endogenous HCG derived from an early pregnancy. The preceding ovarian response in this woman may be unremarkable. Late ovarian hyperstimulation syndrome tends to be more prolonged and severe than the early form. The symptoms of ovarian hyperstimulation syndrome are not specific, and there are no diagnostic tests for the condition. Hence, care must be taken to exclude other serious conditions that may be present in a similar manner but require very different management. Careful assessment by an experienced clinician may be needed, along with full blood count, serum electrolytes, and osmolality, pelvic ultrasound scan, and in selected cases, abdominal imaging. The combination of elevated hematocrit and reduced serum osmolality and sodium is indicative of ovarian hyperstimulation syndrome. OHSS by itself is not commonly associated with severe pain, pyrexia, or signs of peritonism. The presence of these features should lead to a thorough clinical review and investigation to rule out other diagnoses. Important differential diagnoses include pelvic infection, pelvic abscess, appendicitis, ovarian torsion or cyst rupture, bowel perforation, and ectopic pregnancy. OHSS should not, therefore, be the default diagnosis for women presenting with abdominal pain during fertility treatment. Table number 1. Relevant history from a woman suspected to be suffering from ovarian hyperstimulation syndrome or OHSS. History. Time of onset of symptoms relative to trigger. Medication used for trigger. Human chorionic gonadotrophin or gonadotrophin releasing hormone agonist. Number of follicles at final monitoring scan. Number of eggs collected. Were embryos replaced and how many? And polycystic ovary syndrome diagnosis. Symptoms: abdominal bloating, abdominal discomfort and/or pain, need for analgesia, nausea and vomiting, breathlessness, inability to lie flat or talk in full sentences, reduced urine output, leg swelling, vulval swelling, and associated comorbidities such as thrombosis. Table number 2. Examination and investigation of women with suspected ovarian hyperstimulation syndrome or OHSS. Examination. General. Assess for dehydration, edema, pedal, vulval, and sacral. Record heart rate, respiratory rate, blood pressure, and body weight. Abdominal. Assess for ascites, palpable mass, peritonism, measure girth. Respiratory. Assess for pleural effusion, pneumonia, and pulmonary edema. Investigations. Full blood count, hematocrit, hemoconcentration, C-reactive protein, severity, urea and electrolytes, hyponatremia and hyperkalemia, serum osmolality, hypoosmolality, liver function tests, elevated enzymes and reduced albumin, coagulation profile, elevated fibrinogen and reduced antithrombin, human chorionic gonadotrophin to determine outcome of treatment cycle, if appropriate, and ultrasound scan, ovarian size, pelvic and abdominal free fluid. Consider ovarian Doppler if torsion suspected. Other tests that may be indicated: arterial blood gases, D-dimers, electrocardiogram, ECG and/or echocardiogram, chest X-ray, and computerized tomography pulmonary angiogram or CTPA, or ventilation perfusion or VQ scan. Assessing severity and reporting adverse outcomes. How is the severity of ovarian hyperstimulation syndrome classified? The severity of OHSS should be graded according to a standardized classification scheme. Table number 3. Proposed RCOG classification of severity of ovarian hyperstimulation syndrome. Category: mild ovarian hyperstimulation syndrome. Features: abdominal bloating, mild abdominal pain, and ovarian size, usually less than 8 centimeters. Moderate ovarian hyperstimulation syndrome. Moderate abdominal pain, nausea, with or without vomiting, ultrasound evidence of ascites, and ovarian size, usually 8 to 12 centimeters. Category: severe ovarian hyperstimulation syndrome. Features: clinical ascites, with or without hydrothorax, oliguria, less than 300 milliliters per day or less than 30 milliliters per hour, hematocrit greater than 0.45, hyponatremia, Sodium less than 135 millimoles per liter. Hypoosmolality, osmolality less than 282 milliosmol per kilogram. Hyperkalemia, potassium greater than 5 millimoles per liter. Hypoproteinemia, serum albumin less than 35 grams per liter. And ovarian size, usually greater than 12 centimeters. Category: critical ovarian hyperstimulation syndrome. Features: tense ascites, large hydrothorax, hematocrit greater than 0.55, white cell count greater than 25,000 per milliliters, oliguria and/or anuria, thromboembolism, and acute respiratory distress syndrome. Legend A: ovarian size may not correlate with severity of OHSS in cases of assisted reproduction because of the effect of follicular aspiration. Women demonstrating any feature of severe or critical OHSS should be classified in that category. Rarely, ovarian hyperstimulation syndrome may be associated with life-threatening complications including renal failure, acute respiratory distress syndrome or ARDS, hemorrhage from ovarian rupture, and thromboembolism. The precise risk of mortality from ovarian hyperstimulation syndrome is unknown. How should ovarian hyperstimulation syndrome be reported? Licensed centers should comply with Human Fertilization and Embryology Authority or HFEA regulations in reporting cases of severe or critical OHSS among their patients. Units that treat women with ovarian hyperstimulation syndrome should inform the licensed center where the fertility treatment was carried out to promote clinical continuity and to allow the licensed center to meet its legal obligations. Any death related to ovarian hyperstimulation syndrome in the UK must be reported to mothers and babies, reducing risk through audits and confidential inquiries across the UK or MBRRACE UK, irrespective of whether the woman was pregnant. The Human Fertilization and Embryology Authority, or HFEA, requires that all incidents be reported verbally within 12 working hours, followed by a completed incident form within 24 working hours of the incident being identified. Since women with OHSS are often admitted to centers other than the treating unit, it is important for the admitting center to inform the originating clinic. The duty to report cases of ovarian hyperstimulation syndrome to the Human Fertilization and Embryology Authority, however, lies with the person responsible of the licensed center providing the fertility treatment. Organization of services. How should care be delivered for women at risk of ovarian hyperstimulation syndrome? Fertility clinics should provide verbal and written information concerning OHSS to all women undergoing fertility treatment, including a 24-hour contact telephone number. All acute units where women with suspected ovarian hyperstimulation syndrome are likely to present should establish agreed local protocols for the assessment and management of these women and ensure they have access to appropriately skilled clinicians with experience in the management of this condition. Licensed centers that provide fertility treatment should ensure close liaison and coordination with acute units where their patients may present. In certain situations, the clinicians looking after a patient with ovarian hyperstimulation syndrome may lack experience in managing this condition. Efforts should be made to reduce the risk associated with this by patient empowerment and coordination of services between licensed centers and the acute units where their patients are likely to present. Women should be informed of the symptoms of ovarian hyperstimulation syndrome and of the importance of reporting this. Information concerning OHSS should be delivered face to face to all patients undergoing fertility treatment, backed up with written information and advice including a 24-hour contact. They should be advised to mention that they are undergoing fertility treatment even if they present with an apparently unrelated symptom such as headache or visual disturbance. Initial assessment. How should women suspected of suffering from ovarian hyperstimulation syndrome be assessed? Women presenting with symptoms suggestive of ovarian hyperstimulation syndrome should be assessed face to face by a clinician if there is any doubt about the diagnosis or if the severity is likely to be greater than mild. The aim of initial assessment is to establish the diagnosis and grade the severity of ovarian hyperstimulation syndrome. Women with symptoms of ovarian hyperstimulation syndrome may in the first instance be assessed over the telephone. It is important for staff triaging women over the telephone to have a clear understanding of the women who will require face-to-face clinical review. A specific inquiry should be made for significant abdominal pain, shortness of breath, or a subjective impression of reduced urine output. These symptoms may indicate severe ovarian hyperstimulation syndrome and the occurrence of specific respiratory, renal, or ovarian complications. Face-to-face clinical assessment allows examination and investigations with the aim of clarifying the diagnosis and severity of the patient's condition. Outpatient management of ovarian hyperstimulation syndrome. Which patients with ovarian hyperstimulation syndrome are suitable for outpatient care? Outpatient management is appropriate for women with mild or moderate ovarian hyperstimulation syndrome and in selected cases with severe ovarian hyperstimulation syndrome. What management is appropriate in the outpatient setting for patients with ovarian hyperstimulation syndrome? Women undergoing outpatient management of OHSS should be appropriately counseled and provided with information regarding fluid intake and output monitoring. In addition, they should be provided with contact details to access advice. Non-steroidal anti-inflammatory agents should be avoided as they may compromise renal function. Women with severe OHSS being managed on an outpatient basis should receive thromboprophylaxis with LMWH or low molecular weight heparin. The duration of treatment should be individualized, taking into account risk factors and whether or not conception occurs. Paracentesis of ascitic fluid may be carried out on an outpatient basis by the abdominal or transvaginal route under ultrasound guidance. There is insufficient evidence to support the use of gonadotropin-releasing hormone antagonists or dopamine agonists in treating established OHSS. It appears reasonable to encourage patients to drink to thirst rather than a set amount. Fluid intake of at least 1 liter a day should be advised. Outpatient management may be aided if patients are able to maintain fluid input-output charts. Urine output of less than 1,000 milliliters per 24 hours or a positive fluid balance of greater than 1,000 milliliters over 24 hours should prompt medical review to assess severity. Paracetamol and oral opiates, including codeine, can be offered to women for pain relief. Women with severe ovarian hyperstimulation syndrome are at an increased risk of thromboembolism. Thromboprophylaxis should be provided for these women in view of the serious nature of this complication. Small observational studies also suggest that dopamine agonists may have a beneficial role in the treatment of established ovarian hyperstimulation syndrome. Further research is required to evaluate these interventions. How should women with ovarian hyperstimulation syndrome managed on an outpatient basis be monitored? Women with ovarian hyperstimulation syndrome being managed on an outpatient basis should be reviewed urgently if they develop symptoms or signs of worsening OHSS. In the absence of this, review every 2 to 3 days is likely to be adequate. Baseline laboratory investigations should be repeated if the severity of OHSS is thought to be worsening. Hematocrit is a useful guide to the degree of intravascular volume depletion. In the majority of women with OHSS, the condition is self-limiting. The object of monitoring is to identify women who suffer an increasing severity of ovarian hyperstimulation syndrome and may require further measures. In most women, the condition resolves over a period of 7 to 10 days. If conception occurs, endogenous human chorionic gonadotrophin can lead to a worsening of OHSS, whereas in the absence of pregnancy, recovery is usually complete by the time of the withdrawal bleed. Clinicians and patients should be vigilant for signs that the severity of ovarian hyperstimulation syndrome is worsening. These include increasing abdominal distension and pain, shortness of breath, tachycardia or hypotension, reduced urine output, less than 1,000 milliliters over 24 hours, or positive fluid balance, more than 1,000 milliliters over 24 hours, weight gain and increased abdominal girth, and increasing hematocrit of greater than 0.45. Inpatient management. When should women with ovarian hyperstimulation syndrome be admitted? Hospital admission should be considered for women who are unable to achieve satisfactory pain control, who are unable to maintain adequate fluid intake due to nausea, who show signs of worsening OHSS despite outpatient intervention, who are unable to attend for regular outpatient follow-up, and who have critical OHSS. The value of admission lies in the possibility of closer monitoring, ease of intervention, and availability of multidisciplinary input. This is crucial in the care of women with critical ovarian hyperstimulation syndrome who may be at imminent risk of complications or who have already developed complications that may require intensive care. Each case should be considered on its merits with reference to the clinical features, social factors, and the expertise available. Women with less severe ovarian hyperstimulation syndrome may also benefit from admission depending on their social situation and the availability of out-of-hours expertise. The need for paracentesis is not in itself an absolute reason for admission. Who should provide care to women with ovarian hyperstimulation syndrome? Multidisciplinary assistance should be sought for the care of women with critical OHSS and severe OHSS who have persistent hemoconcentration and dehydration. Features of critical OHSS should prompt a consideration of the need for intensive care. A clinician experienced in the management of ovarian hyperstimulation syndrome should remain in overall charge of the woman's care. Patients with severe ovarian hyperstimulation syndrome where dehydration and hemoconcentration persist despite adequate fluid replacement may need invasive hemodynamic monitoring, requiring input from anesthetic and intensive care colleagues. Intensive care is also likely to be needed for women with critical OHSS, while specific complications such as thromboembolism, ARDS or acute respiratory distress syndrome, and renal failure require input from relevant specialties. How should women with ovarian hyperstimulation syndrome be monitored? Women admitted with OHSS should be assessed at least once daily. More frequent assessment is appropriate for women with critical OHSS and those with complications. Inpatient monitoring of women with ovarian hyperstimulation syndrome aims to track changes in the severity of the disease process and to identify any complications at an early stage. Body weight, abdominal girth, and fluid intake and output should be measured on a daily basis, along with full blood count, hematocrit, serum electrolytes, osmolality, and liver function tests. Depending on the clinical features, arterial blood gases, ECG, chest X-ray, and other imaging may be required. Increasing abdominal girth, weight gain, oliguria with positive fluid balance, and elevated hematocrit are signs of worsening OHSS. Conversely, recovery is signaled by a diuresis, normalization of hematocrit, and a reduction in abdominal girth and body weight. C-reactive protein levels have been shown to correlate with other markers of OHSS such as abdominal girth and weight, and may have a role in monitoring severity. How should the symptoms of ovarian hyperstimulation syndrome be relieved? Analgesia and antiemetics may be used in women with OHSS, avoiding non-steroidal agents and medicines contraindicated in pregnancy. Relief of abdominal pain and nausea forms an important part of the supportive care of women with ovarian hyperstimulation syndrome. Severe pain may signal a complication, such as ovarian torsion or rupture, or a coincident problem, such as ectopic pregnancy or pelvic infection. What is the appropriate management of fluid balance? Fluid replacement by oral route, guided by thirst, is the most physiological approach to correcting intravascular dehydration. Women with persistent hemoconcentration, despite volume replacement with intravenous colloids, may need invasive monitoring, and this should be managed with anesthetic input. Diuretics should be avoided as they further deplete intravascular volume, but they may have a role in a multidisciplinary setting if oliguria persists despite adequate fluid replacement and drainage of ascites. Vigorous intravenous fluid therapy with crystalloids has the potential of worsening ascites in the presence of increased capillary permeability. Hence, the oral route should be used for hydration wherever practicable. Some patients may need effective analgesia and antiemetics in order to be able to maintain adequate fluid balance. Acutely dehydrated women may need intravenous fluid therapy to correct fluid balance, followed by oral fluids to maintain hydration. Crystalloids are useful for the initial correction of dehydration in women who are unable to maintain adequate oral intake. Human albumin and hexaethyl starch, or HES, have been used for correction of dehydration in women with severe ovarian hyperstimulation syndrome. However, HES has been withdrawn in the UK as a result of evidence showing increased mortality in critically ill and septic patients receiving HES compared with those receiving crystalloids. Human albumin solution, 25%, may be used as a plasma volume expander in doses of 50 to 100 grams infused over 4 hours and repeated 4 to 12 hourly. Strict fluid balance recording should be followed for these patients. Persistent hemoconcentration or low urine output despite apparent adequate volume replacement by colloids is an indication to seek multidisciplinary assistance. In these cases, continuous urine output measurement and invasive hemodynamic monitoring may help guide fluid management more accurately. Oliguria, despite adequate fluid replacement, may in some cases respond to paracentesis. There is a risk of worsening hypovolemia if diuretics are administered without correcting dehydration. Careful use of diuretics may be appropriate in women who continue to exhibit oliguria despite adequate fluid replacement, particularly if any tense ascites that may have been contributing to oliguria has been drained. How should ascites and effusions be managed? Indications for paracentesis include the following: severe abdominal distension and abdominal pain secondary to ascites, shortness of breath and respiratory compromise secondary to ascites and increased intra-abdominal pressure, and oliguria despite adequate volume replacement secondary to increased abdominal pressure causing reduced renal perfusion. Paracentesis should be carried out under ultrasound guidance and can be performed abdominally or vaginally. Intravenous colloid therapy should be considered for women who have large volumes of fluid removed by paracentesis. Paracentesis should be carried out under ultrasound guidance to avoid trauma to the enlarged vascular ovaries. Both abdominal and transvaginal routes are well described. Abdominal paracentesis allows the insertion of an indwelling catheter, and this may minimize the need for repeat paracentesis. Most reports on transvaginal paracentesis describe aspirations in a single sitting. Patients with ovarian hyperstimulation syndrome are generally a younger age group and are likely to tolerate the removal of large volumes of ascites in a different way to elderly patients with malignant ascites who may experience significant fluid shifts in such situations. It has been suggested that early drainage of ascites to lower the intra-abdominal pressure in patients with moderate to severe ovarian hyperstimulation syndrome may prevent disease progression and lower the risk of severe complications associated with this condition. Drainage of 2,000 milliliters of ascitic fluid in women with severe OHSS produce significant reductions in intra-abdominal pressure and renal vascular resistance. Studies have described autotransfusion of concentrated ultrafiltered ascitic fluid protein aiming to replenish the woman's albumin levels using her own protein, reducing the risk of infection and allergic reaction to exogenous albumin. How should the risk of thrombosis be managed? Women with severe or critical ovarian hyperstimulation syndrome and those admitted with ovarian hyperstimulation syndrome should receive low molecular weight heparin prophylaxis. The duration of LMWH or low molecular weight heparin prophylaxis should be individualized according to patient risk factors and outcome of treatment. Women with moderate ovarian hyperstimulation syndrome should be evaluated for predisposing risk factors for thrombosis and prescribe either anti-embolism stockings or low molecular weight heparin if indicated. In addition to the usual symptoms and signs of venous thromboembolism or VTE, thromboembolism should be suspected in women with ovarian hyperstimulation syndrome who present with unusual neurological symptoms, even if they present several weeks after apparent improvement in OHSS. Severe ovarian hyperstimulation syndrome is a prothrombotic state due to hemoconcentration and vascular endothelial dysfunction. The incidence of thrombosis has been estimated to lie between 0.7% and 10% of cases of ovarian hyperstimulation syndrome. The incidence of this complication and its potentially life-threatening nature mean that thromboprophylaxis should be given to women with severe ovarian hyperstimulation syndrome and those with risk factors such as reduced mobility, obesity, or a pre-existing thrombophilia. Anti-embolism stockings should be used in patients admitted to hospital with ovarian hyperstimulation syndrome for whom chemical thromboprophylaxis is contraindicated as they are likely to have reduced mobility. Several case reports describe thromboembolism occurring weeks after the apparent resolution of ovarian hyperstimulation syndrome, particularly in association with pregnancy. The majority of delayed thrombosis are reported to have occurred in the first trimester of pregnancy. Hence, in women with severe OHSS who conceive, thromboprophylaxis should be considered at least until the end of the first trimester. In general, The duration of thromboprophylaxis should be based on individual risk factors and whether or not conception occurs. Liaison with a specialist hematologist may be beneficial in individualizing therapy. Thrombosis in women with ovarian hyperstimulation syndrome frequently affects upper body sites and frequently involves the arterial system. Therefore, clinicians should remain vigilant of patients presenting with unusual symptoms such as dizziness, loss of vision, and neck pain. Women may present with thromboembolism several weeks after apparent resolution of ovarian hyperstimulation syndrome. If a thrombosis is suspected, then therapeutic anticoagulation should be instigated while appropriate imaging is arranged. These patients should be managed in collaboration with colleagues in hematology and maternal medicine. When is surgical management indicated? Surgery is only indicated in patients with ovarian hyperstimulation syndrome if there is a coincident problem such as adnexal torsion, ovarian rupture, or ectopic pregnancy, and should be performed by an experienced surgeon. Hyperstimulated ovaries are likely to be highly vascular and liable to damage on handling. The risk of ovarian torsion or rupture appears to be increased in women with ovarian hyperstimulation syndrome, particularly in the presence of pregnancy. Laparoscopic untwisting of torted hyperstimulated ovaries has been described. The presence of ovarian enlargement and ascites should be kept in mind when considering a diagnosis of ectopic pregnancy. In rare cases of critical ovarian hyperstimulation syndrome, termination of pregnancy has been reported in the situation of progressive thrombosis despite anticoagulation, and there have been cases reported for removal of the ovaries, bilateral oophorectomy for intractable ovarian hyperstimulation syndrome. However, this is not a recommended treatment option. Ovarian hyperstimulation syndrome and pregnancy. What are the risks associated with pregnancy and ovarian hyperstimulation syndrome? Clinicians should be aware and women informed that pregnancies complicated by ovarian hyperstimulation syndrome may be at increased risk of preeclampsia and preterm delivery. Controlled studies do not show an increase in the risk of miscarriage in pregnancies arising from assisted reproduction cycles complicated by ovarian hyperstimulation syndrome compared to cycles without ovarian hyperstimulation syndrome.